Welcome back, physicians in training. What makes one diagnostic test better than another? In today's clinical vignette, we're going to walk through how to differentiate between two valid answer choices to make sure you pick the right one on game day. Let's jump into it. I know you've been studying hard to hit the ball out of the park on the USMLE, so let's jump into our next USMLE-style vignette question step-by-step walkthrough. Which of the following is the most appropriate next step to confirm the diagnosis? A 34-year-old woman presents to the clinic with complaints of fever, joint pain, and fatigue for the past 2 weeks. Considering the demographic of a female patient, fever, joint pain, and fatigue are nonspecific, but concerning for a systemic inflammatory or autoimmune process. Conditions like systemic lupus erythematosus (SLE), rheumatoid arthritis (RA), or systemic vasculitis come to the forefront of my mind. She notes that her symptoms have worsened progressively, and she feels exhausted even after a full night's sleep. She also reports a painful sore in her mouth and a facial rash that worsens with sun exposure. Fatigue disproportionate to rest suggests systemic inflammation, immune dysregulation, or hormonal imbalance. Although oral ulcers can be seen in multiple pathologies such as Behçet's disease, pemphigoid, and leukoplakia, they are hallmark features of SLE when combined with a photosensitive facial rash. Other autoimmune diseases, such as dermatomyositis or subacute cutaneous lupus erythematosus, could also present with photosensitive rashes. She denies recent travel, new medications, or any sick contacts. The lack of recent travel or sick contacts makes infectious causes such as endocarditis or parvovirus B19 infection less likely. Her past medical history is unremarkable, and she takes no regular medications. There is a family history of autoimmune disease, with her mother having rheumatoid arthritis. No medication history rules out drug-induced lupus or other medication-related conditions. A family history of autoimmune disease increases the likelihood of an autoimmune disorder due to genetic predisposition. On physical examination, her temperature is 38.2 degrees centigrade, blood pressure 120/75, heart rate is 88 beats per minute, and respiratory rate is 16 breaths per minute. The examination reveals a malar rash, swollen and tender small joints in her hands, and oral ulcers. Fever confirms systemic inflammation or infection, supporting the autoimmune hypothesis over non-inflammatory causes like fibromyalgia. Swollen, tender joints with rash are observed in SLE, psoriatic arthritis, and adult still disease. A complete blood count shows hemoglobin 11, white blood cell count 3,500, platelets 120,000. Additional laboratory tests reveal serum creatinine 1.2, positive anti-nuclear antibody test. Anemia, leukoplakia, and thrombocytopenia suggest bone marrow suppression and also support systemic involvement, potentially pointing to pancytopenia due to autoimmune destruction. Mildly elevated creatinine raises suspicion for early lupus nephritis. A positive ANA test is highly sensitive to autoimmunity, making it an important screening tool. Which of the following is the most appropriate next step to confirm the diagnosis? The differential diagnoses include rheumatoid arthritis, Behçet's disease, dermatomyositis, and infectious endocarditis. However, this vignette most strongly supports SLE. Let's review the answer choices now using a process of elimination strategy. A. Complement levels, C3 and C4. Indeed, low complement levels C3 and C4 are often seen in active SLE due to immune complex deposition and consumption of complement. However, they cannot diagnose SLE alone. Alternatively, they are more helpful in assessing disease activity once the diagnosis is established. Therefore, I will eliminate this answer choice. B. Enzyme-linked immunosorbent assay, ELISA, for anti-Smith antibodies. Anti-Smith antibodies are highly specific for SLE. However, they are seen in a smaller percentage of patients and are not commonly used as the first confirmatory test after a positive ANA. Nevertheless, I'll keep this answer choice for now. C. Urine protein to creatinine ratio. This test assesses proteinuria and helps detect lupus nephritis, a serious complication of SLE. However, it is not the best initial test to confirm SLE. It should be considered after the diagnosis is supported by autoantibody testing. Therefore, I will eliminate this answer choice. D. Skin biopsy of the mallow rash. A skin biopsy may show changes consistent with lupus dermatitis, also known as interface dermatitis, but it is not typically used as a confirmatory test for systemic lupus because serologic tests are more definitive. E. Anti-double-stranded DNA antibody testing. Anti-double-stranded DNA antibodies are highly specific for SLE and often used as a confirmatory test following a positive ANA screen. They are seen in approximately 70% of patients, and SLE correlate well with disease activity, especially in cases of lupus nephritis. Answer B. Anti-Smith antibodies can be eliminated because although they are specific to SLE, they have lower sensitivity seen in only 20 to 30% of patients. Therefore, E is the best answer to this question. That concludes this USMLE-Style deep dive walkthrough. Make sure to check out the free SLE PDF summary and hit that like button if you've received value watching this video. Leave a comment to help direct the content on this new channel. As a new channel, we aim to meet your preferences. If you haven't heard yet, we will give away a prize to one lucky subscriber after we reach 500 subscribers. You don't want to miss out. Until next time, stay sharp and focused, and continue to elevate your clinical mastery.